Hello, my name is Doug Smith. I am one of the emergency physicians at Danbury Hospital. Many of you may know me. For those of you who don't, I've been here about 6 years now, and I've been asked to speak with you today on penetrating trauma by Dr. Saad for your Nuvance EMS lecture series. Thank you very much for having me. So let's get started. So pre-hospital management for penetrating trauma. What I'd like to do today is go through some of the things you may see on trauma calls for penetrating trauma. The basic approach to the management of these traumas will be reviewed based on the type of injury. So first, a definition. So penetrating trauma occurs when a foreign object pierces the skin and enters the body, creating a wound. The object remains in the tissue or passes through the tissues and exits the body. Or in blunt trauma, the skin is not necessarily broken. So that's kind of the breakdown of most things we see in trauma, right? Either something hits a body or a body hits something, like a car accident, and that would be blunt, or something enters the body, or the body is impaled on something, that would be penetrating. Those are the two big categories. Obviously, most things we see are blunt, but the smaller subset is penetrating. Thankfully, though, that is the area where there is more that can be done for those traumas. So let's get into it. Most penetrating trauma that we think about is either going to be gun-related or some sharp object entering the body, stabbings. Basics of management include, like everything else, ABCs. Fluids, we'll go into this a little bit more in depth later as to why fluid is so important for these cases. Getting access to give the fluids, and then treating the likely pathology. We'll go through these cases one by one and tell you how to manage them, and then get here quick. So the main disease processes that we will be talking about, pneumothorax being one of the biggest ones, and then tension pneumothorax in particular. Pericardial tamponade, this would be when the sac surrounding the heart, the pericardium, is filling with fluid and impeding blood filling into the ventricle, and therefore impeding blood moving forward. Abdominal hemorrhage, extremity sanguination, and then cervical vascular injury. So for most chest penetrating trauma, if it's causing hemodynamic instability, this is what they'll be getting at arrival. This is an open thoracotomy. It's how we access the chest to either deliver the heart from the pericardium, manage any other intrathoracic bleed, etc. This is if the chest tube is ineffective, that is, and we'll go through that. But obviously, this isn't going to be happening in the field. So how do we treat the patient when we don't have the ability to open up the chest like this? So let's go through first tension pneumothorax. This is one of the more common sequelae injuries that we'll see after penetrating trauma to the chest. So what will you see? Unequal breath sounds, hemodynamic instability, and sometimes even an expanding hemithorax. You can see in this chest x-ray, which I realize isn't something that you're looking at pre-hospitally, but you can kind of get the impression that that heart right in the middle here shouldn't be here. The heart should be here. This whited out lung that you see around the heart, I wouldn't say whited out, but opacities here, does not look the same as over here. This darker appearance between the ribs, that is air, where there should be lung tissue. So that needs to be decompressed. So how do we do that? First, let's choose a site. This is a chest tube. This is what they'll be getting when they arrive. So we anesthetize the skin if we have time or hemodynamic instability to do so. and then cut down and introduce a tube using a Kelly clamp into the thoracic cavity, therefore decompressing it. So that's after they get here. What about pre-hospital? We pick our site for our chest tube based on these anatomic landmarks. And we'll go through this. Generally, the 5th intercostal space is where we'll place a chest tube in the mid-axillary line or anterior axillary line. But before getting to the hospital, of course, the easier way to do the same job to decompress the chest is with a needle. You're probably aware that most studies have found that a regular angiocath used in this manner is not going to be adequate. You may have noticed that some of our patients are not the 70 kilogram size that we see in our test mannequins. We have many patients who have a much larger anterior abdominal wall or chest wall, I should say, and are going to require a more length in the catheter in order to access that chest. So these devices, which I believe you all carry, provide a 14 gauge angiocath with a longer shaft that can make it into most chest cavities. So the principles of needle decompression: mid-clavicular line, 2nd intercostal space. When you introduce that catheter, you may or may not hear the rush of air. As we said, an angiocatheter is likely inadequate. In a pinch, you can try it and it might work, but it might not. An alternate site, if you have, let's say, just an angiocath and you're not getting that rush of air on a larger patient, you could try where we place chest tubes. This has been found in CT and MRI studies to be the site where the thoracic wall is the least deep. So you might be more likely to get access at the 5th intercostal space along the anterior axillary line. And this will almost always be converted to a chest tube once you arrive in the ED. So here you go, mid-clavicular line, the blue line, MCL. You're going to shoot for the 2nd intercostal space. This is really essentially just right under, inferior to the clavicle. The anterior axillary line being the other site, you're going to move a little bit lateral, just anterior to the axillary fold, and go down a bit further to the 4th or 5th intercostal space. Both would be acceptable spots to go. So what if you have an open intrathoracic wound? You have a sucking chest wound. You see air being sucked into that wound. That's certainly going to cause a pneumothorax. This will be an open pneumothorax. Now, how do we prevent that air from being sucked into the chest wall and therefore worsening the pneumothorax? We use a 3-sided dressing. You might have in your kits a Heimlich valve for this type of patient. If you do, great, pop it over there, and that will allow air out, but not in, which is the goal. If you don't, this 3-sided dressing is the way to go. So some kind of occlusive material over the actual site, 3 sides to it with tape, and then air will be able to escape through that open side. But when it tries to go back in, it'll suck and adhere to the chest and not let air back in, which is the goal. Nothing terribly fancy there, but very effective. So moving on, pericardial effusion. How do we diagnose this? Usually a penetrating trauma to the chest or epigastrum. You're going to hear potentially muffled heart sounds. You're going to have hemodynamic instability, hypotension. You might see distended neck veins. Why is that? Because the returning blood coming back to the heart is not going to be able to return as we like it to, and it's going to back up. You'll see that in the neck veins being full. How do we treat this in the hospital? We'll go to that. We'll talk about that in a moment, but pre-hospitally, fluids wide open. Just give them fluids, and volume. And that will increase the fluid and the volume coming back to the heart, and therefore overcome that afterload or the pressure that the returning blood has to overcome in order to create forward flow. So if you suspect this, you're going to be giving them fluids anyway for penetrating trauma that's hemodynamically unstable. Just know you can keep giving it and keep giving it, and that's the right thing to do here. Here you can see a healthy heart and a heart undergoing tamponade. So you see this black area with the arrows pushing on the ventricle and not allowing that to fill and expand. So more fluid coming back into the heart is going to improve that pressure and allow that filling to happen better. So that's chest. Let's move on to abdominal trauma. There's not much to go over here because if you have a large penetrating or small penetrating wound to the abdomen, there's not much that's going to be done pre-hospitally besides fluid administration that's going to help. You just got to get them here quick. But if you do have a large gaping wound, then packing can really be effective. This has been shown in battlefield medicine. These are surgical towels, but really whatever material you have in your rig, even just gauze, packing that in there to provide some pressure can tamponade off that bleeding and slow the exsanguination. But either way, pack them or don't if you're not able to, if it's a small bullet hole or something, and just get them here quick. There is a very new technology in the last few years called REBOA, that is the resuscitative endovascular balloon occlusion of the aorta. As you see here, this is an X-ray view of, it's a little bit enhanced, but it's a rendering of a central line placed into the femoral vein with a catheter snaked up into the aorta, femoral artery, I should say, and then blown up or deployed at the level of the aorta. This causes basically what we would do in open thoracotomy, which is a cross clamping of the aorta, and prevents any bleeding distal to or inferior to that site. Not something we generally do here, not even something that is done at major institutions, but something that is done at certain spots, certain emergency departments, and an interesting thing to know about anyway. Extremity trauma. This is something that you guys drill and train on frequently. So clearly, extremity injuries, people can bleed out very fast. Just apply the tourniquet, note the time that the tourniquet was applied, but I don't want you to fret too much about how long the tourniquet is up. People undergoing knee replacements, for instance, will have a tourniquet applied in the OR for hours, and they're not going to have an ischemic limb. It's not going to go necrotic and fall off. It'll be fine. So put that tourniquet up, tie it nice and tight to stop the hemorrhage, and get here quick. But please do note the hemorrhage or the tourniquet time, because they'll want to know that for the trauma team. Cervical penetrating trauma. So we'll go over the zones of injury in a moment, but the basic management that you're going to need to worry about pre-hospitally is really holding pressure and controlling the airway. Here are the zones 1, 2, and 3. Always goes backwards in my head when I try to think of it, because 3 is up top, but basically it's from the lobe of the ear to the angle of the mandible. And then zone 1, I remember from the cricoid cartilage down to the clavicles, and zone 2 is everything in between. This is not necessarily something you'll need to remember. However, if you wanted to throw that in during your patch, you'd look pretty, you'd look like a stud. Identifying what zone a penetrating injury is in, because that can help us prepare what we're going to need to get ready here. But the main thing is going to be airway control. So penetrating trauma to the neck is often going to cause bleeding into the airway structures, which obviously poses a problem. This scary video laryngoscopy view shows you blood beginning to pool up under the area epiglottic folds and filling up that airway. Just a couple more seconds or a minute more, that'll be brimming over the epiglottis and into your airway, which poses some problems. So bottom line, intubate them early if you have penetrating cervical trauma. And if it's already gotten to the point where there's blood everywhere, then just shoot for the bubbles, literally. You'll see when the patient tries to exhale, bubbles coming at you. Remember your eye protection. And you basically try to put the tube into those bubbles. And most of the time you will hit the trachea and not the esophagus if you do that. But the bottom line for most of these, penetrating trauma to the chest, get that air out. You can do a finger thoracostomy if you really want to get creative. That's what we do here prior to the chest tube, but really your needle decompression is going to be the way to go. Penetrating trauma to the abdomen, pack if you can, if it's a large defect. Otherwise, fluids, and get them here. Penetrating trauma to a limb, put that tourniquet on and note the time, and then get them here quick. Penetrating trauma to the neck, hold pressure, early airway intubation, and transport. So this was not a terribly long lecture. These are pretty simple principles, but these are pretty sick patients. So please feel free to reach out with any questions. Douglas.smith@nuvancehealth.org. And I'd be happy to chat with any of you. Thanks so much for listening and for what you guys do for our patients